हे केलं पण नाही होते.
चालत नाहीये ते.
राईट कॉर्नर विथ द बेस ऑफ द
आत्ताशी सुरू झालंय ते. काय माहिती काय मायग्रेन वर आहे आता.
आता होत आहे?
नाही होते सर.
Whiteboard soon.
सर नेक्स्ट स्लाइड दाखवा म्हणजे लक्षात येईल आपल्याला. दिसते का सेकंड स्लाइड? हा दिसते सर.
ठीक आहे
ओके सर. ओके सर.
ओके ठीक आहे.
So migraine is a kind of headache characterized by recurrent episodes of moderate to severe throbbing and pulsating pain, usually on the side of head. The pain is caused by activation of nerve fibers within the blood vessel walls traveling inside the meninges. Usually the attack lasts from 4 to 72 hours. So it is the usual definition of the migraine. These are the diagnostic criteria of the migraine, which are given by the International Headache Society in 2016. Patient should have at least 5 headache attacks that should last for 4 to 72 hours. And the headache must have at least 2 of the following characteristics.
Sir, excuse me, sir. Sir, third slide. Next slide.
I am already on third slide.
We are unable to see the third slide, sir.
We are on second slide.
Yeah.
पुढे जात नाही ते.
I guess it's internet lag.
अपने 2 marks स्कूल रहता है.
लाईट पुढे जात नाहीये.
आता जाते?
नाही
आता दिसते सर. येस आता जाते.
आता ओके.
Fine. So the headache should have at least 5 episodes. The attack should last for 4 to 72 hours, and it should have at least 2 of the following characteristics. It should involve unilateral location, means hemicranial headache, pulsating or throbbing nature, moderate to severe pain intensity, and aggravation by causing avoidance of routine physical activity. Okay, by doing exercise, walking, etc., etc. In addition of this, during the headache, the patient should have at least one of the following things involved. It should be nausea or vomiting and photo or phonophobia. Okay, so these are the criteria, diagnostic criteria, means that patient should have at least 5 episodes before we label him as migraine. So any new episode of migraine which we consider should be labeled as migraine only if the patient is having any previous history or patient is having family history of migraine. And these natures, hemicranial nature, this throbbing quality of the headache, moderate to severe intensity of the pain should have been there. At least 2 of these following characteristics, and the additional finding should be either photo or phonophobia or nausea or vomiting should have been there. Then only we should diagnose it as migraine. Okay. So these are the usual triggers of migraine. As we know, there is sudden change in weather, there is reduced sleep or too much of sleep, strong odors or fumes, emotions, stress, overexertion, noises, motion sickness, low blood sugar, then skipping of meals, tobacco, depression, anxiety, hangover, and some medications also can trigger migraine. Hormonal changes can trigger migraine, and bright light and flashes also can trigger migraine. Okay, so these are the usual triggers of migraine. So now migraine is divided into 4 phases. These are the clinical characteristics of the migraine: the premonitory symptoms, the aura, the headache, and the post-stroke. Now the premonitory symptoms usually occur 24 hours prior. These include abnormal food cravings, unexplained mood changes, either euphoria or depression, then uncontrollable yawning, fluid retention. The patient a sense, a feeling of, bloating and increased urination. These are the premonitory symptoms that can occur 24 hours prior to the headache. Aura is basically either visual most commonly, or it can be sensory, it can be motor, or it can be anything which are the transient symptoms prior to the migraine, and the aura can be from few minutes to half an hour or so. And then the headache usually lasts from 4 to 72 hours. In the definition, it is given that it can last up to 72 hours. Okay, it usually builds gradually in the intensity, and it is possible that migraine can have no headaches. I mean, it is possible that migraine can have without headaches. Okay, all these symptoms, premonitory symptoms, aura, and without headache also there can be migraine. And the postdromal symptoms after these headaches are usually the patient feels exhausted and confused following a migraine. Okay, there are two major types of migraine. One is called as classic migraine, that is migraine with aura, and the common migraine, that is migraine without aura. So the most common migraines are migraine without aura, and the classic migraines are migraine with aura. Now, what are the aura? Which are the auras? We can see the visual disturbances and the other neurological symptoms that appear 10 to 60 minutes before the actual headache and usually last no more than an hour. Individuals may temporarily lose, some part of the vision. The patient or the aura may occur without headache, which can strike at any time. Other classic symptoms include trouble in speaking and abnormal sensation, numbness, muscle weakness, and tingling sensation on the face, and transient confusion as well. Nausea, loss of appetite, and increased sensitivity to light may, precede the headaches. And this migraine without aura, it's basically which is called as common migraine, which is more prevalent and frequent type of migraine than migraine with aura. The symptoms include headache, and the pain that occurs without warning, usually felt like one side of the head, which associated with throbbing, severe, intense pain, associated with nausea, confusion, some mood changes, fatigue, and intolerance to light and sound and noise. Now, there are some types of migraine which I'm going to discuss here, which are being labeled as variants of migraine. Now, abdominal migraine. Abdominal migraine mostly affects young children and involves moderate to severe pain in the middle of their abdomen, lasting from 1 to 72 hours, which is with little or no headache. Additional symptoms include nausea, vomiting, loss of appetite. Many children who develop abdominal migraine also have migraines headache later in the life. So initially in the life, they just presents with abdominal pain, and later they presents with headache. Then hemiplegic migraine. This is a type of migraine which is rare and severe form of the migraine, which causes temporary paralysis. Sometimes it lasts several days on one side of the body prior or during a headache. Symptoms such as vertigo, stabbing sensation, speaking issues, swallowing issues may begin prior to headache and usually stop shortly thereafter. So this hemiplegic migraine, it's a severe form of migraine where it is actually being confused with transient ischemic episodes or stroke. Sometimes patients of stroke or sometimes patients of hemiplegic migraine are considered as a stroke, and they have been thrombolized as well. Okay. When this familial migraine or hemiplegic migraine runs in families, it is called as familial hemiplegic migraine. There is a genetic association of this hemiplegic migraine, which is there in the form of familial hemiplegic migraine. Though it's rare, there are 3 distinct genetic forms that have been identified. Basilar type of migraine, it mainly affects the children and young patients. It occurs most often in teenage and associated with their menstrual cycles. Symptoms include partial or total loss of the vision, or double vision or visual complaints, dizziness most of the time, poor muscle coordination, slurred speech, ringing in the ears, etc. Menstrual migraine, it affects female around their menses. Almost all female they with migraine, they have this kind of headache. The symptoms include migraine without aura, pulsating pain, hemicranial, and increased sensitivity to sound and light. Ophthalmoplegic migraine, it is an uncommon form of migraine with headache associated with drooping of eyelid, large pupil, and double vision that may last for weeks, even the pain is gone. Retinal migraine. This is also very rare form of migraine associated with attacks of visual loss or disturbances in one eye. These attacks are more common with visual auras and associated with migraine headaches. Status migrainous. This is also a rare condition which is associated with disabling severe pain, which can last for 72 hours or more. And the pain and nausea usually intense, and the patient need to be hospitalized, and it usually doesn't respond to the normal abortive treatments. So these are the variants of the migraine. So the commonest variant we see here is basilar type of the migraine, where patient usually presents with giddiness and headache. And the other type of migraines are status migrainicus, which is also nowadays being common because of rampant use of abortive treatment measures or abortive treatment by the patients. So now aura. So migrainous aura is a complex neurological symptom that usually precede or accompany the headaches. It may occur in isolation as well. So aura can be preceded by headaches, or there is only aura without any headache also. It usually develops over 5 to 20 minutes, and it can last for 60 minutes. And it can be either visual, sensory, or motor, or any combination of this. So usually the visual aura symptoms are negative symptoms include scotomas or negative visual phenomena such as anopias, homonymous anopias, or quadratic field defects, central scotomas, tunnel vision, altitudinal field defects, and complete blindness. And the positive symptoms are macropsia, achromatopsia, and other symptoms can occur. The typical scintillating scotomas occur prior to the headache, which is a the sign for a classic migraine. It is sometimes called as portification spectrum because of the serrated edges of the hallucinated basations around it. I can show you the images of how the scintillating scotomas look like to the appeared for the patient. The sensory auras. The sensory auras, patient can feel paresthesia. It can occur in around 45% or 40% of the patients. It can occur in isolation or usually associated with visual aura. They are often oral or perioral, can present in hand as well as legs, and they can jump from one side to the another side. The rate of spread of the sensory aura is helpful to distinguish between the TIA and a sensory seizure. So there is a difference between TIA, sensory seizure, and aura. So the rate of spread usually is the differentiating point between these three episodes. Visual aura spreads around the visual field slowly, and then paresthesias may take over 10 to 20 minutes to spread, which is really slower than a TIA or a seizure. Motor symptoms. Now, motor symptoms of aura can accompany 80% of the patient, usually associated with sensory symptoms. They can usually associated with heaviness of the limbs. Then the speech and language disturbances can also be reported in 20% of the patient. So these are the different type of auras. Now we can see what auras exactly look like. So this is the fortification spectrum. The patient can see like this fortification spectrum. So this is the central scotoma. If there is a patient of migraine, if he is not able to see the central part of the face of the person, it is called as central scotoma. These are multiple scotomas. Here the patient is not able to see in a picture at multiple sites. And this is hemianopia, homonymous hemianopia. The patient is not able to see one side of the picture. So these are the different visual auras. Now, as we say that migraine is a familial disease, the family history is important. Approximately 70% of the patients have first degree of the relative with history of migraine. The risk of migraine is increased fourfold in relatives of the people who are having migraine with aura. Migraine headaches generally show a multifactorial inheritance, and the genetic pattern is not really very specific. So around 70% of the patients with the migraine have a family history, which is more significant. So migraine is associated with multiple comorbidities. The associated diseases with migraine are epilepsy, dyslipidemias, then Tourette syndrome, then tremors, which are essential tremors, then sometimes amyloid angiopathy. Strokes are more common. Migraine with or as a risk factor for stroke, ischemic stroke. Depression and anxiety is usually associated with migraine. Asthma is also most of the time associated with migraine. Obesity and post-traumatic stress disorder are usually associated with migraine. So these are the comorbidities that are usually associated with migraine. Now, what are the differential diagnoses of the migraine? If there is any patient of headache, which usually comes to your OPD, then these are the differential diagnosis. Migraine is a type of primary headache, so we have to differentiate this from the two other primary headaches. The two other primary headaches are cluster headache and tension type headache, and there are multiple other secondary headaches. The secondary headaches are either vascular or inflammatory or traumatic or stress related, etc. So we have to differentiate it from other primary headaches. The other primary headaches are cluster headache. The cluster headache is usually come in clusters. So the patient can have attacks lasting from few minutes to 3 hours, usually 1 to 2, or usually maybe 1 to 3 per day. And they usually come in cluster, like the patient gets an attacks for 15 days, then there is no attack of headache for few months or maybe few days, and then the patient can throw again episodes of headaches. So in cluster headache, the episodes last for few minutes to 2 to 3 hours, while in migraine they can last from few minutes to 72 hours. So that is the difference between cluster headache and migraine. Cluster headache also hemicranial. It is also associated with some trigeminal autonomic activity, which is also seen in cluster headache. So it is difficult really to differentiate between cluster headache and migraine. Usually the cluster headaches start at night, which is very rare in migraine, and usually the cluster headaches are very severe than migraine. The patient usually lands up in casualty, due to the headache. Tension type headaches are dull headache. They are usually occipital and they are usually diffuse. They can last for hours and days, and they are not really debilitating than migraine. So this is the differentiating points between these primary headaches. Now the differential diagnosis for secondary headaches. So sudden severe headache, cerebral aneurysm, so CVST, then chronic paroxysmal hemicrania, cluster headaches, as we discussed, dissociation syndromes, dissection syndromes like cervical carotid dissection or vertebral artery dissection. They can also simulate like migrainous headache or headache of severity. See, herpes simplex encephalitis, or for that matter, even zoster, shingles, eruptions of the rash also can present initially with headache and later the rash comes. So the encephalitis as well as zoster can present usually initially as hemicranial headache. Intracranial hemorrhage can also present with a hemicranial headache initially. Then temporal arteritis is also one of the reason for headache. It should be ruled out. Tolus-Hunt syndrome, viral meningitis, all these are the differential diagnoses which can be seen in day-to-day practice. This should be differentiated from migraine. So now, treating about migraine. So basically, diagnosis is important. Rule out secondary causes is very much important. Then you should assess the disability of the patient. Whether the patient needs any treatment or not is equally important. Most of the migraine patient, they usually doesn't require treatment. They are not that disabled. If the patient is disabled, the patient should be educated about the trigger factors. The patient should be educated about mental as well as physical health. Then there is a individual management, and there is a the family should be educated about this, and the care should be stratified. So this is the usual approach for migraine treatment. Now there are two forms of treatment in migraine. One is called as acute migraine treatment, that is called as abortive treatment, and the second treatment is called as prophylactic treatment. So acute migraine treatment usually helps in preventing the acute episodes of headache. So if the attack is severe, then the patient should be treated with this treatment. Usually for mild to moderate headaches, we use analgesics or NSAIDs, aspirin, non-opioid analgesic, acetaminophen, etc. And for moderate to severe episodes, triptans are used. Triptans can be used orally, sublingually, nasally, as well as intramuscular. And if the patient is not taking orally, then the non-oral options are very limited. So in that case, we can use subcutaneous sumatriptan, then ergotamine injections or intranasal spray or corticosteroids. If the patient requires in a hospital admission for that, so parental formulations of the triptans, ergotamines, antiemetics, anticonvulsants, valproate, or sometimes corticosteroids and magnesium sulfate can be used for acute migraine treatment. So the second most important part is preventive treatment, and selecting the agent to prevent the episodes or prophylaxis for the migraine is really important. If the migraine episodes are more than 4 per month, then or four episodes per more than per month, then the patient should be selected for the treatment. Okay, and plus there is a contraindication or failure to or overuse of the acute treatments, then the patient should be given preventive treatment options. Active treatment have adverse effects, that then preventive treatment can be taken over. Oral, the basic thing is basically start oral treatments at low doses with a single agent and then titrate slowly. It should be given at least for 8 weeks initially and to optimize the therapeutic response, and then should be slowly tapered. Okay, so the preventive treatment, the American Academy of Neurology and the Headache Society, they have given some recommendations. So the level A recommendation is for anti-epileptic drugs, including the divalproic sodium and topiramate. Beta blockers of A level recommendation is propranolol and timolol and sometimes metoprolol, but propranolol and timolol has been approved. Metoprolol is not that much approved. Triptans are also approved. Which triptan is the fugatriptan? It is for short-term management of prophylaxis, not for acute prevention, but for short-term management. The level B recommendations are for antidepressants like amitriptyline and venlafaxine, then beta blocker atenolol and notalol, then triptans like naratriptan and zolmitriptan, they can be used for prophylaxis. So these are the recommendations. Level C recommendations are for ACE inhibitors, ARBs, beta blockers, and alpha blockers as well. So now coming to individual agents, now the abortive medications, we use serotonin agonist. These are the agents which are used for abortive medications. Serotonin 5-HT1F agonist, these are called as dietans. They are used as abortive medication. Triptans, that is selective serotonin receptor agonist, that is 5-HT1B and 1D. Then the calcitonin gene-related peptide receptor antagonist, that is CGRP antagonist. Then ergot alkaloids, then analgesics and NSAIDs, and the combinations and antiemetics. So nowadays there is a research going on CGRP antagonist in a big way, that probably the headache management is going to be changed with these medications. So we'll see it shortly. So these are dietans. These are serotonin 5-HT1F agonist. Now these are the 5-HT1F receptor agonist, which do not elate vasoconstrictive effect, whereas triptans cause vasoconstriction via agonistic action on this 1B and 1D receptors. So these are very much specific. The dietans are specific and they prevent the vasoconstriction effect of the triptans. So dietans are more specific than triptans. So usually we don't use triptans in coronary artery disease and where there is a peripheral vascular disease because they cause vasoconstriction. So this side effect is usually avoided by dietants. The dietan which is used is lasmitran, and the dose is usually 50 to 100 mg oral. Then these are the triptans. They are selective serotonin agonist for 1B and 1D receptors. The common side effects are nausea, vomiting, dizziness, somnolence, and tightness and discomfort in chest. For the same matter, they are not used when there is a coronary artery disease or there is a vasospastic reaction, and they should not be used in with ergot containing drugs, which usually causes vasospastic reactions. Now, sumatriptan, which is the most commonly used triptan in India, it is 1B and 1D receptor agonist. The drug delivery options for these are either oral or subcutaneous or intranasal. In case of emergency, it can be used intranasal as well as subcutaneous. The efficacy is 82% at 20 minutes when administered by injection, and when administered orally, it is around 80% at 4 hours. In naratriptan, again, the bioavailability and the half-life is
हॅलो ज्योती.
हा हॅलो.
हा सर, वाटतं इंटरनेट प्रॉब्लेम आहे का तिकडे?
हो ना, ठीक आहे, कॉल करते सरांना.
तू करतेस का?
हा करते.
नो ऑडियो म्हणजे त्यांनी
हाँ सर जॉइन होता है.
ओके.
Sorry for interruption. Am I audible now?
Yes, sir.
Yes,
Yes.
Yes, sir.
Okay, so okay, so the next treatment, abortive treatment option is ergot derivatives. So the ergot derivatives are say, selective 5-HT1 agonist that have a wide spectrum of actions. They are used for abortive treatment for moderate to severe types of migraine headaches. They are usually dihydroergotamine and ergotamine tartrate. Then the next abortive treatment option is non-opioid medications, then opioid analgesic, then in opioid, basically oxycodone and morphine and methadone can be used sometimes. We usually discourage the use of opioid analgesics, but they can be used sometimes in refractory cases. Then NSAIDs, they are COX inhibitors. They inhibit inflammation as well as the arachnoid acid cascade, which is basically inflammatory cascade which initiates the pain and inflammation. They are generally used in mild to moderate kind of headaches. Ketorolac is wonderful drug. Ibuprofen, naproxen, aspirin, and celecoxib can be used for the episodes. Now, mm, anticonvulsant drug, anticonvulsants mainly are used for prophylaxis. The main drug is valproic acid, that divalproic sodium. It is a enhancement. It enhances GABA transmission, so which suppresses the inflammation related to migraine and sympathetic activity over sympathetic activity related to migraine. It is shown to reduce the migraine frequency by around 50%. Then topiramate is usually prescribed in adults, not in children. So there are multiple actions: augmentation of GABA activity, then blockade of sodium channels, and so that's why topiramate is also used in migraine prophylaxis. The benefit of topiramate is basically it can be used in patients who are obese or overweight. Usually, all the other medications of migraine causes obesity, including divalproic sodium, then beta blockers, and then calcium channel blockers. But topiramate is the drug which can be used in obese patients with migraine. It usually reduces the obesity. So again, beta blockers, as we've seen that the selective beta blockers are used. Propranolol and timolol have been approved for this. Metoprolol is not usually being used for migraine. The beta blockers should be avoided in cases of asthma with migraine. Then now CGRP monoclonal antibodies. These are going to be change the management of the migraine. They are used nowadays outside India, not in India. They are still awaiting the Indian FDA approval. So this CGRP peptide is a potent vasodilator, and it's a key neuropeptide that initiates the migraine pathophysiology. So there are these four maps, RNO maps and Fremeno maps and other maps. They are being used outside. So now CGRP, these are CGRP monoclonal antibodies. They are usually, the monoclonal antibodies are being given usually by intravenous or subcutaneous routes. Now this CGRP antagonist, so they bind the CGRP receptor, and these are the names of these agents. Rimagepant and Arbogepant, and they are being used orally or available in the tablet form. They are used in migraine. So now, as we use very widely this calcium channel blocker flunarizine, they have best documented efficacy, but flunarizine is not being used outside, especially in US. In India, it is being used very widely. Verapamil is being given to the patients with comorbid hypertension and those who are having contraindication for beta blockers and asthma. They are having very good efficacy. They reduce the headache by around 50%. So the next management or for chronic migraines or Botox or botulism toxins are used. The injections are given in the affected side of the skull, or sometimes even bilaterally. and they are usually used for prevention of chronic migraines. Okay, so it is also showing good efficacy, the botulism toxins. So we are using Botox very rarely for migraines, especially when there is a chronic migraine, then only we are using it. So there are now other treatments for chronic migraine as well. So they are called as neuromodulation treatment. So there is a device which was launched, day before yesterday, Nervio by Dr. Reddy's. The device has to be applied on the hand, and the device usually, gives some vibrations at certain frequency. That vibration should be used should be given for around 45 minutes per day, alternate day. And they claim that it is very effective way of reducing migraine frequency as well as severity of migraine without any side effects. So there are trials which are done on these devices. So it is very, it's like a iPhone which has to be used on applied on the arm via binder, and it gives some impulses and it reduces the frequency and intensity of the migraine. So these are these neuromodulation techniques nowadays which are coming for migraine treatment. So I'm done with this. Any questions?
Hello.
Yes, madam.
Hello, sir. I'm Dr. Dipali. Thank you very much, sir. And I think this topic is no more mystery for anyone now. And as everyone, and as this topic was very elaborative, and we got to know that the migraine is not only just about headache; it can be generated or it can be elicited by the bacillary, or that can be ophthalmic origin, can be abdominal origin, and we can say it can be a menstrual migraine, and there are different type of migraine that we got to. But now my viewers have many more questions that I will just let you know. First question is from Gayatri Khatri, that how to differentiate between migraine and trigeminal neuralgia. Adding to this, I just wanted to add from my side that now just we saw that there are many symptoms which are related to which we need to differentiate from the neurological symptoms. For example, as you told that in ophthalmic migraine there is drooping of eyelid. It can be we can differentiate. We need to differentiate from myasthenia gravis. So how to differentiate it from migraine or any neurological?
So first, I will take the questions for trigeminal neuralgia. Okay. So migraine is a headache, which is a kind of primary headache, and there are three other primary headaches. The first one is migraine, which is more common. Then tension type headache, which is also more common. Then the third one is cluster headache, and the fourth one is called as trigeminal autonomic cephalgias. Okay. So these trigeminal autonomic cephalgias, they consist of 3 to 4 entities. Okay. So where the pain is trigeminal nerve related and it lasts for few seconds only. So, okay, in trigeminal neuralgia also, the trigeminal nerve is affected. The trigeminal nerve is affected by most commonly vascular inflict, where the vascular artery or any vein, touches the or inflicts the nerve, trigeminal nerve, and the pain occurs because of that. The pain is very sharp shooting. It usually involves only one segment of the trigeminal nerve. The most common is either V1 and V2 segment. V3 segment is rarely affected. It is unilateral, but the pain is only for short duration. The triggers for trigeminal neuralgia are either cold air, either washing of the face, either chewing something or eating something, or may not be anything. So the pain is very neuralgic pain. In migraine, the pain is throbbing pain. So the neuralgic pain and throbbing pain, these two are different. So that's how the trigeminal neuralgia is being differentiated by migraine.
Okay. So Dr. Mansi wants to know that what is drug-dependent migraine and why migraine is more common in females.
There is some terminology called as medication overuse migraine or drug-dependent migraine. So whenever the frequency of migraine is more, patient tends to consume more medications, and at that time, so the patient is dependent on medications. So whenever the patient misses the medication, the patient gets a rebound headache. Okay, so that this is called as medication overuse headache or medication associated headache, which is commonly associated with migraine.
Mr. Santosh is saying whether migraine episode can cause short or long-term memory loss.
Yes, basilar migraines usually can cause short-term memory loss. Basilar migraine can present as transient global amnesia-like episodes.
Dr. Pratik Kulkarni is asking which group we should not combine with prescription. Which group?
First choice in so first of all, the patient should receive abortive treatment or preventive treatment. It depends on the number of frequencies. Okay, if the patient is getting more than 5 episodes per month, then only justified to give prophylactic treatment. Otherwise, the patient should prescribe, we should prescribe only abortive treatment. And then in prescribing prophylactic treatment, the first option, if the patient is not asthmatic, should be beta blocker. And the second option should be other agents like valproate and flunarizine.
Pushkarat wants to know that whether strawberry, chocolate eating or such coffee, they can provoke the migraine attack.
Different patients have different trigger factors. So some patients usually get triggers by drinking excess of coffee. Anything excess can trigger migraine. Normal consumption usually does not trigger migraine.
So, I think Shalendra Rajput, I don't understand whose name is this, but whether there is vestibular migraine or Meniere's migraine, what is difference the diagnosis between vestibular and Meniere's syndrome?
The Meniere syndrome is usually not associated with headache. The migraine or the migraine associated vertigo is usually having history of headaches. May not be the headache should be present at the time of vertigo, but he should have at least some history of headaches previously.
So Dr. Sabka is
And
asking, yes, Dr. Sabka is asking whether during pregnancy the treatment is same or they have to take certain precautions for migraine.
beta blockers like propranolol can be used in pregnancy. But this is the only drug which is being approved for prophylactic treatment in pregnancy. Magnesium supplementation, which usually prevents headache, they are also allowed in pregnancy. So these are the only two drugs at present which are allowed in pregnancy.
And Dr. Kulkarni is asking, is migraine can cure permanently?
So as I said initially, it's very mysterious. Migraine is a very mysterious term. It's not a mysterious disease, but it's a mysterious term. Okay, so it's not a disease per se. Okay, so it's a tendency. If there are lots of things which we have to control, and then we can. It cannot be cured. It can be controlled.
After getting attacked, Dr. Jayashree Sapnis wants to know that how can we prevent further attacks? Is there any regime so that we can prolong or we can avoid the attack, migraine attack?
Usually, the attack can be avoided by taking good sleep, then proper meals at a timing, avoiding exertion, by avoiding excess of anything. So this way we can avoid the attack episodes and to treat it if we get any symptoms and we know that the patient is going to get an attack or even the individual person is going to get an attack, he should take the abortive treatment and he should take rest during that.
Is there any role of barometric pressure in migraine? Can you comment?
Barometric pressure.
Barometric pressure.
I'm not aware of this.
Santosh, please excuse us. And any more questions, please? Okay, what is the side effect of flunarizine and what is the duration therapy?
The usual side effect of flunarizine is weight gain, which is the most common thing, and flunarizine sometimes can cause drug-induced Parkinsonism-like phenomenon. Okay, so these two things should be kept in mind, and it should be discontinued as early as possible.
And is the vertigus migraine? What is the drug of choice in vertigus migraine? Dr. Singh is asking.
So for abortive treatment, as we already discussed, if there is a vertiginous migraine, the abortive treatment should involve analgesics or triptans. So this one, and for symptomatic treatment, we can use any antihistaminic like Stemetil or promethazine, etc.
Dr. Sabnis, can we continue more question or we need to stop there? Deshri ma'am, can we have more questions or?
Yes, sir is having time.
Can we continue with more questions or?
You can continue with 2 or 3 questions. No.
Okay.
Sir is having time.
Yes. The next question is the new machine. Okay, the new machine has one. Oh, sorry. Sorry, I think it's over. So thank you very much. Question from my side, sir. So as we know that stroke is now it has a period of 3 hours to normalize and all. So if there's some symptoms, like as you told that many of times the patient is being normalized also. So how to differentiate whether it was a migraine headache or it is stroke? Because in initial period of 6 scan it is normal or 6 scans are normal.
We should consider every neurological deficit of emergent origin as a stroke only. Even if you thrombolize a stroke, and if you come to know that later that it is a migraine, hemiplegic migraine, it doesn't matter. Okay, we have to confirm that whether it is a migraine or hemiplegic migraine or a stroke. But if you are not sure, then still we have to thrombolize. Thrombolysis is important. If we come to know later that it is a hemiplegic migraine, then it's okay. It doesn't cause any adverse effect. But thrombolizing a migraine, it does not increase the risk of bleeding unless the patient is having any bleeding problem. So you should consider it as a stroke and thrombolize it. We have done also these mistakes that we have thrombolized many hemiplegic migraines, but it is always better to thrombolize if there is no bleeding risk or tendency.
Exercise or any certain physiotherapy can control the migraine is from one doctor.
Yes, a total, it's altogether a different topic of behavioral treatment of migraine, and it is very important with more than these medications, that behavioral treatment of migraine is really very important. So, more than physiotherapy, physical health and mental health is important, to prevent episodes of migraine.
Thank you very much, and we have answered all the questions up to the mark. Thank you very much. Now I hand over the charge to Dr. Prakash Martin. Sir, please take over the charge.
Thank you, Vishal. It was exhaustive and very informative. Why we thought of taking this particular topic, migraine, because I realized that when we pass out from MBS, BHMS, BAMS, people think that migraine is only classical migraine. Half-sided headache, vomiting, aura, prodrome, then post-ictal phase and all those things. They don't realize that it is a very common headache. Any common headaches is also migraine. And as we saw right now, when Vishal told us of the big spectrum, it's not a disease, it's a syndrome. And there is such a big spectrum. I doubt whether any other disease has got so many symptoms. You must have listed at least 40 to 50 symptoms. So that was the reason for us to put this particular topic today. And I think you have done real justice to it. Just out of interest, I'd like to make a passing note that what we see in our clinic, patients म्हणतात की मला पित्त झालं आणि डोकं दुखतं, पित्तामुळे डोकं दुखतं. Now, it is difficult to explain this. It is a type of migraine only. It is a common migraine probably, a variant of classical migraine probably. But ते म्हणतात पित्तामुळे आमचं डोकं दुखतं. तर is there an explanation? Because see, Ayurvedic people say that this is pittamuळे डोकं दुखतं. While we have got both H1 and H2 receptors in the stomach, they get stimulated at the same time during the migraine attack. And that's why these people get vomiting also at the same time, headache also. Is this the explanation for that particular type of headaches and vomiting associated together?
Most of the patients usually, tend to go to the gastroenterologist for the same reason. And most of the gastroenterologists usually prescribe migraine medications only. Okay, but, that is a that is a spectrum of migraine. As you said that it is a multi-system involvement is there. So the receptors are present there. The nociceptive receptors, even in the area prostema, they also tends to get inflamed with this all these neuropeptides. And because of the same thing, nausea and vomiting is a predominant symptom of the migraine. So the pitta prakriti. So that's why migraine is a prakriti. It's not a disease.
Right. I think thank you very much. Thank you very much first for the MCF team, Dr. Jayshree Sunil, Dr. Deepali Bhujbal, then Dr. Jyoti Shinde, and Dr. Pradnya Sapkal. Well, thank you very much. You conducted the lecture, this particular lectures very well. Secondly, thank you, Dr. Vishal Deshpande. We really want to have you more and again, because every month we have got this disease. We are thinking of so many other symptoms concerned with neurology. We'll have you once more. And thank you all. Thank you, all the participants who have joined in huge numbers. I think the number touched about 100, about half an hour back. Thank you very much. Okay.
Thank you, sir, and thank you, Mukta Foundation, very much, and all the best for your future.
Thank you, sir.
Chalo, Jyoti.
Yes, sir. Yeah.
Yeah, bye.
Recording.